Today we're going to check the doctor's orders. And we check the doctor's orders, we're checking for if the patient has any isolation precautions, because if so, we have to put on our personal protective equipment to make sure we don't transmit any diseases. So we check the doctor's orders. Also, one of the things while we're out here, we're going to look at the vital sign sheets. Under the heading vital signs, we're going to look and see what the previous temperature, pulse, respiration, and blood pressure were, and oxygen saturation, so we can compare it when we have to look at the trends. That means how the vital signs, if they go up and if they're going down. So I'm getting ready to go. What I'm going to do is I'm going to get ready to knock on the door. Nursing! I'm going to wash my hands, which the hand sanitizer is outside the patient's room. I had to knock on the door to make sure that I let them know I'm entering their residence, and wash my hands to prevent transmission infection. Good afternoon. My name is Mrs. Kyle. I'm going to be your nurse today. And what we're going to come in here, and I'm going to take your temperature, pulse, respirations, and blood pressure. Now, I don't want to use the term vital signs because unless people know what that means, if you say vital signs, so you want to explain that you're going to take temperature, pulse, respiration, and blood pressure. Can you give me your name, please, and your date of birth? I'm going to check the name and date of birth with the wristband using my two identifiers per Joint Commission. And the National Patient Safety Code is IDing the client. I'm going to make sure I elevate my bed to working height. And it should be between my hips to my mid-thigh to, my mid-thigh to my waist level. And I'm going to see, especially if I'm doing a rectal temperature. So I pull the curtain. Make sure I pull it. Okay, Mr. Pierce. First of all, before I take your temperature, I want to make sure if I'm going to take an oral temperature that they're not unconscious, because an unconscious person cannot make a tight seal with their lips. And if you don't make a tight seal for your lips and you're doing oral temperature, you won't get a good temperature reading. You're going to get probably a false low reading. Also, I'm going to make sure they're not a mouth breather, and if they can't hold the thermometer, that's not the best method for me to take it. So then I would actually take an axillary temperature. So axillary temperatures, I want to make sure that I don't take the temperature after causing friction. I want to make sure their under armpit is dry, but I don't rub and cause friction, because if I cause friction, what's going to happen is going to elevate the temp. And if they have a temperature, that is not the best method to take, because, or if they have hypothermia, because it won't be an accurate reading for them. If I'm going to do a temperature such as a tympanic temperature, that is a thermometer that's placed in the ear, and it reads the core temperature off the tympanic membrane. And if I put in their ear, what happens is, if I have impacted earwax or a hearing aid device, it won't read the core temperature correctly. So we want to make sure that's not the good choice for them. Also, if I'm going to take a rectal temperature, I want to make sure the patient has not had hemorrhoids or any rectal surgery or any bleeding or any impacted stool, because if I try to do that, I'm going to be reading the temperature of the stool if I put in the rectal thermometer in that area. So I want to make sure I don't do that. So Mr. Pierce, we're going to take your oral temperature, and of course, because my patient is a mannequin, I'm going to do my own oral temperature. But I need to know to ask my patient, have you had anything to eat and drink for the last 20 to 30 minutes? Because if somebody had something to drink cold, then that would lower the temperature. If they have something to drink that's hot, that would make the temperature be elevated. So you want to make sure you get an accurate temperature. So you need to wait at least 20 to 30 minutes. Also, if they smoke, what happens when they smoke, the nicotine causes the vasoconstriction of the vessels, and when the vessels are vasoconstricted, the heart works harder, which increases the basal metabolic rate, and that will increase the temperature as well. Mr. Pierce, do you have any signs and symptoms of temperature? So that would be like if they might have some chills or they feel nice and warm, like that, then you know they have a temperature, so you want to know. Okay, when I go to take the temperature, I'm going to use different thermometers. I'm going to select the correct thermometer for the type. This particular thermometer has a blue tip on it. This blue tip here is actually to take an oral temperature or an axillary temperature. So this is called a SureTemp. This is what the facility we're going to uses. We want to make sure we put, when we take this off, we want to make sure that we look here, and it has a picture of a little man with it flashing. So if the head's flashing on this side, that means we can do the oral temperature. If we push it again and the body's flashing, it means axillary. And then we have to use the red one, this thermometer that has a red temp on it, and that means we're going to be doing a rectal temperature. So it's the same type of thermometer, but the red tip, and it has the red probe. And it would have the bottom part flashing, and that means for the rectal area. It also will take, if you want to push again, change it too, you can change it for children to rectal temperature. And that's mostly what we do, that use the rectal temperature for as children. So because we're going to do the oral temperature, we want to make sure our thermometer's clean. So we're going to clean it using an alcohol wipe to make sure we get it nice and clean. We don't want to transmit infection back and forth to each person, so when we first start, we're going to clean it when we use it on a patient. If you have a patient that is in isolation, you would not, if you take a thermometer in there and they have you take one, you want to use a disposable thermometer, or take one and leave it in there until they leave, and it's what we do, terminal cleaning. Okay, so with these, the oral temperature, you're going to make sure you put the sheath on the thermometer, make sure it's set, the head is flashing. And we usually use centigrade or Fahrenheit. You can do the calculation to change it, but most of the time we use Fahrenheit. We're going to make sure we put this sheath on. This covers it to prevent the transmission of infection. This goes underneath the tongue, which there's 4 vessels under there that reads the temperature. And make sure you make a tight seal. And then when it's done, it will beep. 99.0 degrees. And so we're going to make sure that we put this in the trash can. You can just push the end of it and the sheath will come off the trash can. When you're putting the sheath on, be careful, because if you push this, it can cause it to fly across the room there. So we want to make sure. So when it beeps. So make sure, like I said, if we're doing axillary temp, we're going to make sure we put a different sheath on. We're going to make sure the axle is dry. We're going to put this on here. We're going to make sure we change it to the body is flashing. We're going to put the probe facing up toward the patient's head. We're going to lift their arm and put it across the body, and it will go until it actually beeps. So because this mannequin doesn't have a temperature to it, it won't beep, but it will actually beep when it's done. And then, of course, we can push the button to get rid of the sheath off the thermometer and put it back in. If you wait too long when you're taking the temperature and leave the probe out too long, it will make it so it's not, it will start going off. The next thing we're going to do is I'm going to show you about a rectal temp. So if I'm taking a patient and they're doing a rectal temperature, I'm going to make sure I take and put the sheath on. I'm going to make sure I have something over the patient. I'm going to have the patient turn over on its side. I'm going to make sure I put a pair of gloves on too. Now again, I'm going to assess the area, so if they have any rectal bleeding, any hemorrhoids, and anything like that, I'm not going to take the temperature. So I'm going to put this on, put my gloves on, because I don't want to transmit the bacteria. I'm going to make sure I have a tissue handy so I can wipe this off when I'm done in the rectal area. I'm going to use make sure I put a probe on here. I'm going to change this to the rectal area, so make sure it's flashing. I'm going to lubricate with KY jelly. Since it is water soluble, I'm going to make sure I lubricate it. So I'm going to make sure, because if I don't lubricate it, what's going to happen, it's going to cause the patient injury to the rectal mucosa. So I'm going to make sure I put it on. Now, for different ages, for if I have an infant, the infant would be placed actually on their abdomen, laying on their abdomen. So 0.5 inches for an infant. For a child, you're going to put it in 0.9 inches, and for adult, for 1 inch. And you're going to put it in until it starts beeping. When it's done, you're going to, of course, push the sheath off in the trash can, put that back in there, and you're going to take and you're going to wipe off the rectal area. During this whole time, of course, you would have the curtain pulled, especially because you're doing a rectal temperature, and you would try not to expose the patient for very long. And then I'm going to take off my gloves, and I'm going to wash my hands. Now, one good thing you can do is you can have them take a deep breath. So as you insert the rectal thermometer, that helps the sphincter relax and makes them less stressed when you're doing this. And most of the time, like I said, we're not going to take rectal temperature usually unless it's an infant or somebody that, I've had patients where we had oral surgery or they couldn't do it, they're real unconscious, confused. And make sure you hold on to the rectal thermometer, because a lot of times people, when you put something in the rectal area, it makes them want to tighten up. One time in California, we had a patient that did that, and somebody was not, this is what back in the days we had glass thermometers, and they tightened up, and the glass thermometer went up inside, and they had to have surgery to remove that. I want to make sure I remove gloves and wash my hands. Now I'm going to make sure I clean the thermometer with the alcohol pad to make sure it's all nice and clean. Both of them, the ones that I used. And we're going to put it in a charger, because a lot of them charge. Now, Mr. Pierce, your temperature was 99.0. So if they had a little bit temperature. So one of the things, if you're going to do any interventions, you would document that you gave them like a cool rag across the back of their neck or across their forehead, however you want to do. And we're going to document the temperature. If they had a really high abnormal temperature or really low, like 95 or below is usually hypothermia. Usually above 101, we get concerned with the temperatures above 101. Then we want to determine what the cause of the temperature is, and maybe do some tests. Could be they have an elevated white count, they have an infection. Okay, so I'm going to document here 99.0 degrees Fahrenheit, and I took it orally. So I don't need to orally, but if I have to document like if I used another site, I would put R for rectal or A for AX for axillary, and then oral I just put the temperature degrees. And I'm going to look and check and see if the baseline, what the original temperature was, to see if he has any pattern of the temperature going up or if it's going down. Okay, now we're going on to peripheral pulses. For this purpose of this class, we're only going to do a radial pulse. So when we look at radial pulses, we're going to ask the patient, Mr. Pierce, have you lost any blood? Or do you have a heart condition or any respiratory problems? Of course, if he had a respiratory problems, we'd make sure he's sitting up. Or if they had any diabetes, or again, oxygenation problem. The reason we ask that is because if somebody has a poor heart, they have some kind of heart condition, they have poor pumping of the heart, what happens is the oxygen is not getting through to the tissue, and blood is not getting to the periphery, and so therefore they're not getting what we call cardiac output, so their pulse rate is not good too. So it could be irregular. So we want to make sure. Blood loss, because you're losing red blood cells, and red blood cells is what carries oxygen. Diabetes damages what is called edema of the blood vessels, and the blood flow doesn't go good through the blood vessels when that happens. And of course the lungs are not oxygenating the blood. Also, there's certain things that you need to know. There's medications that cause increase in heart rate. First of all, if you have a medication called albuterol, I don't expect you to know the medication, but albuterol, what it is, it dilates the it dilates the bronchioles, and what happens is, because dilating the bronchioles, it allows blood flow to go through. But at the same time, it causes your heart rate to speed up. So you need to know that albuterol will do that. And also we have a medication, what's called digoxin. And digoxin helps the pumping ability of your heart. It slows it down, but it increases the cardiac output. So you need to know that, because a lot of times if the doctor has ordered for you to give digoxin and you have to take a heart rate, you want to make sure the heart rate stays the normal rate between 60 to 100 before you're going to give this medicine. That's why we need to know about this. Also, if somebody's having physical activity, you're going to have to verbalize these factors. If somebody has physical activity, you have to wait 5 to 10 minutes to do a radial pulse, and also about 10 to 15 minutes to do an apical pulse, because it takes that while for the body to return to baseline, and the basal metabolic rate to slow down. Also, 15 to 20 minutes for senior citizens. If they're being active, it takes them a while for their heart rate to return to baseline as well. And you want to watch out for increased pulse rates, because that can mean increased intracranial pressure in the brain, and that's not good. And we're not going to go heavy into that. Okay, so how do we take the radial pulse? Well, first of all, you're going to take the radial pulse, you're going to take the patient's, and you're going to come across here on the thumb side. This is called the radial artery on here. You're going to feel until you feel like a little ridge. That's called the ulnar ridge. When you come to the ulnar ridge, you're going to come in, so you're going to go laterally, and then you're going to come in medially, about an inch, and then you can feel your own pulse rate. You're going to use the pads of your fingers. You never want to use your thumb, because if you use your thumb, what's going to happen is you're going to pick up your own pulse. So you want to make sure you get the patient pulse. So we're going to count the pulse. It should be evenly spaced beats. So if it's evenly spaced beats, it should be like, that's evenly spaced. That means it's a regular pulse, okay? The normal pulse rate is 60 to 100 beats per minute. Now, if you have the rhythm, we determine if it's evenly spaced beats, it's going to be called a regular rhythm. Now, if it's unevenly spaced beats, say for instance you feel, and it feels like boom, 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 that's an irregular pulse, and so our rhythm is irregular. We also look at what's called the quality of pulse. Now, when we take the pulse, we take it for 30 seconds, and we times it by 2. Usually when we take the pulse, we take the respirations at the same time, because we do not want them to know we're taking respirations, and I'll talk about that later on. So we're going to do 30 seconds times 2 for the pulse, and then 30 seconds times 2 to go right into it to respirations. And then, of course, if the pulse rate's irregular, remember this, take it for 60 seconds totally, and then also take the apical pulse to see if there's any difference there. Because chances are it could be the heart rate is not beating regularly, and what could happen is when the cardiac output is working in your heart, it cannot be getting out to the periphery, and so that's when you get a regular pulse. So it could be the heart's working, but it's just not coming. So you want to take the radial pulse and also do the apical pulse as well. So that's why we use the fingertips, because they're more sensitive. Now, so we're going to note the pulse rate. I told you what the normal pulse rate rhythm was. Quality of pulse. The quality of pulse is pulse strength. So if I've taken the pulse and I do not feel a pulse, that is 0. The quality, that means no pulse. If you get no pulse, what are you going to institute? CPR. Okay? That's a no pulse, okay? A 1 plus, I barely put my fingers here because the fingertips are more sensitive. I barely put my fingers here, and I barely touch and feel the pulse, and the pulse just becomes real weak and you can't hardly feel it. That's a 1 plus pulse. Or kind of like sometimes thready pulse where you just kind of, it's really weak, you can hardly feel it. So that's a 1 plus. 2 plus is I can feel it throughout the whole entire time. It's evenly spaced. I can count it for 30 seconds and multiply it by 2, and it's really easy to get. That's a 2 plus. That's a pulse rate that's within normal limits. A 3 plus is when I barely put my hands on here and all of a sudden, boom, 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 it feels like something's, that's a bounding pulse. Like I barely touch it and I feel like my hand's going to jump off. A bounding pulse, so that's 3 plus. Okay? So I'm going to make sure, Mr. Pierce, we took your pulse rate, and I'm going to make sure I check them bilaterally. Increased pulse is increased cardiac output, and a weak pulse is decreased cardiac output, plain and simple. So when I check it, you're going to check them both for your checkoff. You're going to make sure you check them, and you check them simultaneously bilaterally and compare them to make sure, because it could be they have problems with the right side or the left side heart, so you make sure it's correct. I'm also going to make sure I look at things for inadequate circulation, like we talked about during bathing. If I'm going to check with the dorsal of my hand to make sure their skin is not cool, because again, that's not good blood flow. I'm going to make sure that they have good capillary refill and it's not decreased. So they should, when I push down on the finger and it blanches, the color should return within 3 seconds or less. That means that's good capillary refill. I'm going to also make sure they don't have a bluish or ashen tone to the skin. That means inadequate circulation. So I'm going to put down the pulse rate that he got. It was 68. And the quality was +2, and it was regular rhythm, so I'm going to write that down. And I'm going to compare it with the trends, what's going on. I'm going to check it against the baseline to make sure it wasn't going up or wasn't going down. And so it seems to be within normal limits for him. Now when you do these pulses and stuff, when you do temperature, you would need to be within 2 degrees of the examiner. And the normal temperature, I forgot to mention, was 97.0 degrees Fahrenheit, anywhere up to 99.5. Depends on the person. And we already told you about the pulse. Now, the pulse rate, you need to be within 4 beats of your examiner to pass the checkoff. Okay, let's assess the apical pulse now. So when I'm assessing the apical pulse, I'm going to use this is called a stethoscope. Now, with the stethoscope, you're going to have to make sure you clean it, because you don't want to transfer infections, so you should warm it up and make sure you clean it for your patients. You don't want to put it on. Some nurses go from one patient to the next, and that transmits infection. You don't want to do that. So you go from one to another. Make sure you clean the earpieces too, because you don't want the earpieces in your ear, especially if somebody had some kind of ear infection or something. You don't want to transmit it. So you want to make sure you clean that. You don't want your stethoscope too long, because it's too long you might need to adjust it, because that causes it to be hard to hear of. And also you're going to make sure that when you put these in the ears, it should be facing in towards your eardrum so you can listen. Now when I go to take the pulse rate, I'm going to make sure I can do it several different ways. The patient can be lying or the patient can be sitting. It just depends on the patient. So it could be lying or sitting, or they can be lying on their left side. There's different ways you can do that. Usually children 3 years of age or younger, the rates are faster because their arteries are smaller, so it's not as easy to, so it's a little bit more difficult to access. So we already cleaned the stethoscope, we warmed it for 10 seconds, and you want to make sure it's not too cold because it can cause the heart rate to slow down, of course, because of vessel constriction. We're going to look for what we call the point of maximal impulse. Now, how do you find the point of maximal impulse? Okay, if you find your suprasternal notch and go diagonally, Go on your left side because you're going to most of your heart sounds are on your left, and you go across here, go below your clavicle until you feel a space. This is your first intercostal space, okay? So we're going down to the point of maximal impulse, which is the apex of your heart. We're going to 1, 2, 3, 4, 5. Now, with women, the men, you can always listen to the fifth intercostal space because they don't have tissue, but with women, a lot of tissue there. But with women, you have a lot of breast tissue, so females, you got to go up underneath the breast and make sure you get way up underneath here, and you have to make sure if a person has a bra on that you get way up underneath. So on my patient, I would make sure I listen, but I want to go up underneath the gown, because if you listen over the gown, you're going to hear scratching. So you always want to listen left side, fifth intercostal space, mid-clavicle line, and like for females, it's underneath the breast. You want to listen, and you're going to have these in your ears, and you're going to listen to what we call lub dub. Go here. Each beat, 1, 2, 3, 4. So we're going to listen to the apical pulse for at least 60 seconds. So 60 seconds. We want to make sure if it's below 60 and we have digoxin ordered, we're going to make sure that we hold the medication. We also want to assess if they have low output, their blood pressure is below 60. We're going to ask them, are you feeling dizzy? Because a lot of times they're not getting good blood flow, it's not going to the brain, so we want to make sure they're not dizzy. We're going to make sure they don't have any pain, because pain can elevate the blood pressure and pulse rate, and also they don't have dyspnea, because dyspnea is shortness of breath. If they have a heart rate greater than 100, we're going to take a complete set of vital signs, okay? And we're going to find out, do they have any pain? Because pain can elevate, acute pain will elevate the blood pressure. Do they have any anxiety? Because we all know when people are anxious, their heart rate goes up. Or if any type of fear, anything like that, or fever. Also dehydration will also cause, because you don't have enough fluid in your body and your heart's trying to race harder to put fluid around the system. The other thing you have to make sure is you do when you're done, you have to take an alcohol wipe and make sure you clean off your stethoscope so you won't transmit it to your patient again. So I'm going to note the heart rate. Like I said, for the radial pulse, I'm going to note the heart rate for the apical pulse to make sure if it's the rhythm is regular. I'm going to make sure it's between 60 to 100 beats per minute, and what quality is it's 2+. And also another thing I need to note, I need to have the patient lying flat. I'm going to have her turn their head to the side, and I want to look at their jugular vein on the side. If their jugular vein is distended, that means they have too much fluid in their system. They can have overload of fluid, and you can see a distended vein, or neck vein. But make sure they're lying flat and have their head turned to the side. Okay. Mr. Pierce, your heart rate is about 68. It's the same thing as your radial pulse. I'm going to document it's 68, and it's 2+, and it's regular. So it's the same. I'm going to measure. And I took it at apical pulse, so I'm going to write down AP for apical pulse. And then the other one I should put RT and for right radial. So I'm going to make sure I document that correctly. And again, they have to be documented within 4 beats of the examiner. Now we're going to assess respirations. Now when I'm assessing respirations, I want to make sure that I don't tell them I'm going to assess their respirations, because if you tell the patient you're observing their respirations, they're going to take a deep breath and usually hold it like this, or they're going to breathe funny, so you're not going to get a good respiration rate. So what I usually do is when I'm taking the pulse, I hold their arm across their abdomen like this, I take their pulse, and I count for 30 seconds times 2, and then I can feel also with my hand here, I can feel the rise and fall of the chest at the same time. So the next 30 seconds, So I count for a total of 1 minute. So the next 30 seconds, I'm feeling the rise and fall of the chest. So it should be, the normal respiratory rate should be between 12 to 20 breaths per minute. I'm going to also make sure for the respirations that I observe for signs of respiratory stress. So if I walked in the room and I'm checking their breathing, and all of a sudden I saw them gasping for air, or they have cyanosis, which is, it could be around their lips, it could be in their mucous membrane, it could be like on their extremities. Cyanosis meaning blue, that means lack of oxygen. You better start doing something. That means sometimes probably don't have a good oxygen saturation. One of the first things we do if somebody's having trouble breathing is we set the head of that up completely. We wouldn't leave them lying down flat. So we want to make sure they don't have any cyanosis, and also it could mean they have hypoxemia, which is low oxygen in the blood too. We want to find out if they have any pain, anxiety, or fever, or any respiratory disorders, because that will affect the respiratory rate too as well. And we are trying to count. Now on the infant, if you have an infant, you're going to place your hand on their abdomen and then feel the rise and fall of the abdomen, because infants breathe so fast, like 40 to 60 breaths per minute, so it's going to be harder to follow how they're breathing. We also want to make sure, so you want to make sure if it's normal for the age, and we talked about if they have abnormal respirations, we're going to use the pulse oximeter. Now this little device here is called a pulse oximeter. Now the main things that you're going to remember for the pulse oximeter, you need to assess. So if they're having respiratory difficulty, you're going to make sure you clean the finger. Or I'll clean my finger in the case so you can see what I'm doing here. Make sure it dries, because that again prevents the spread of infection. You don't want to use a pulse oximeter and then go use it on somebody else. You're going to clip this onto patient finger. This has a couple of diodes that are lined up directly. Also, between the diodes being lined up too, when you push this on, you'll see a red flashing light in here. That's where the diodes are, on the top and bottom, and they have to be lined up. You're going to put the finger in, you're going to push the button, and it takes just about a minute to read it. On this, it's going to have the saturation of oxygen in the blood. Okay. We're going to look at the normal saturation should be for somebody that's younger age, like 60 below stuff, usually 95 to 100. As you get older, elderly people, as you get older, over 60, a lot of times some of them, especially with respiratory diseases, run between 90 and 92. The doctor will also write orders for what oxygen saturation to keep their O2 level on. So anybody on oxygen, anybody has a respiratory problem, and any patient, as part of the vital signs, you go and you put this pulse oximeter on and you take their oxygen saturation. So it reads the saturation of oxygen. You know, hemoglobin is what carries oxygen in blood. It reads from hemoglobin, infrared, reads that hemoglobin saturation of oxygen in the blood. So this says my heart rate is 109 and O2 saturation is 97. One thing I'm going to tell you about these, don't believe what they say here, because with the pulse rate almost always, I know my heart is not jumping out of my chest right now, and it's not 109 or whatever like that. So you want to make sure that you take the pulse manually, but the oxygen saturation, you can write that down. So since I'm on oxygen, I'm going to document this as being 96%. And I'm going to put RA, that means room air. That means I'm breathing 21% oxygen, which is room air. Now if I was on oxygen, you're going to read how many, and we'll learn this later on oxygenation, how many liters per minute. And you will write that down, like if it's 1, 2, 3 liters per minute. Or 2 or 4 liters per minute, whatever. So we want to make sure that we have the respiratory rate, and we got that written down. We also want to make sure we write down the depth of respirations too. So if they're deep, they're either deep or shallow. So we're going to write that down too as well. Now, one of the things on here, you make, Mr. Pierce, your respiratory rate was 20 beats per minute, and you're breathing deep. And instead of regular respirations are known as like even. So when I breathe, when my chest is rising evenly, and I'm not breathing fast like this. So we're going to say even and unlabored. If I was breathing fast like this is labored breathing. So we chart it as labored, or even and unlabored, or we can chart it as labored. And then that's when you have to do the pulse ox. There's a couple things I need to tell you about the pulse ox. If their fingers are cold, it will not read correctly. So you're going to make sure you warm the hand. Sometimes you can use a warm washcloth, put it on the hand. I do that too when I'm doing AccuChecks, checking blood sugar. So you want to make sure you get the fingers warm. Make sure the finger gets straightened out, because a lot of times some of them won't read if your finger's a little bit crooked in there. Make sure the person, if they have tremors, like they have Parkinson's or something, or a neurological disease, and they shake, it will interfere. It will cause artifact, and they won't get a good reading. Another thing is, if a person has nail polish on or artificial nails, it won't come through, it won't read them, especially if they're a person that has some respiratory problems. Okay? So I documented all that. I want to make sure if they had labored breathing, then I would want to document on here that they had, I want to check for intercostal retractions. That means intercostal muscles retracting in. You can see that when they're gasping for breath, or you can see them sometimes people breathing using their abdominal muscles. That's use of accessory muscles. Or if you have somebody that their nostrils start flaring out like this, that can mean they have problems with respiratory distress. When you do respirations, you need to be within 2 breaths of the examiner. Okay, blood pressure. Now the last one we're going to do is blood pressure. So when I do blood pressure, Mr. Pierce, have you had any caffeine? Have you smoked or exercised or had any stress? Okay, because what caffeine constricts vessels, and caffeine will cause the blood pressure to go up. So if they had any caffeine, or the same thing with the nicotine, it causes vasoconstriction, increases the vessels, heart to work harder. Or same thing with exercises or stress, you want to wait 30 minutes before you do blood pressure, because you're going to get an accurate blood pressure. You also need to make sure the patient has been lying down for the last 5 minutes, and also you want to make sure that their legs are straightened out. If the person's legs are crossed, you can take blood pressure if they're sitting in the chair or if they're laying down in bed, but the patient's legs cannot be crossed. If the patient's legs are crossed, the heart's going to have to work harder to pump, and so you're going to get elevated blood pressure. So you should always make sure that their legs are uncrossed when they're doing this. They should be laying with their arm out like that, palm up, to make sure you're getting good blood pressure. And if they're sitting in a chair, their feet has to be relaxed and flat on the floor. And like I said, not crossed. The arm needs to be, when they're laying down, the arms needs to be supported here at the level of the heart. Because if it's above, it's not going to detect there's really arm there, so it's not going to pump as hard. And if you have the arm down, it's going to pump harder. If they're sitting in a chair, you want to put it like a table next to them to keep their arm elevated heart level, unless you want to hold it. But I would recommend using overbed table, putting up their level, keep their arm elevated at their heart level. You want to make sure you're going to roll up the sleeve about 5 inches, so make sure that you don't listen over close. When you go to put the blood pressure cuff on, you want to make sure you have the right size cuff. The cuff should wrap 2/3 around the arm. So this on here This is called a sphygmomanometer. It has a manometer here. This is an aneroid manometer. It's a dial manometer. We no longer use mercury in places because that was dangerous to people's health. It has to be an inch up above the antecubital space, and also the arm has to be up, or the sleeve has to be rolled up. You want to make sure you're going to put this right on the artery, so you're going to use the brachial artery. How you find the patient's brachial artery is you're going to have them bend the arm, and you can feel the brachial tendon in the middle here. So when you feel the brachial tendon, you want to go towards the ulnar, right down, right below next to the brachial tendon. And sometimes, guys, if you're real muscular, you might need to pull down a little bit harder. But you can go right next to the brachial tendon, and you can feel like a pulse right in there. So you want to make sure this goes right over the brachial artery. So when I have the tendon right there, you go towards the side, the artery would be right there. So 1 inch above the antecubital space. Make sure the cuff, like I said, goes 2/3 around the arm. If you have somebody that has a larger arm, what you're going to do is make sure that you have a large cuff. Just like if a person has a small arm, small cuff, because if the cuff is too tight on somebody that has a larger arm, what's going to happen, you're going to get a false high reading, or if it's too loose, you're going to get a false low reading. So you want to make sure that's not what happens. And also the sleeve needs to be up, because doing it over clothing, a lot of places will grab your arm, do it over clothing, and that causes constriction, so you don't want to do that. So when we got that up, so you got the fingers. Now what we're going to do is there's 3 reasons. If you see a sign like this, it says no blood pressure or blood sticks in right arm, I wouldn't use this right arm. There's 3 reasons we do not use somebody's arm. The main reasons. One is if somebody has an IV. If you put a blood pressure cuff and you tighten that cuff using the bulb and stuff, and you tighten it, you can cut off the circulation and you can blow the IV. And also it can get clotted, and you don't want to break off any clots and go to the heart, so lungs, stuff like that. Also, if they have a dialysis shunt, meaning if they're a kidney patient, and you try to put this on the shunt, you can clot off the shunt. You don't want that to happen. And the third reason is if somebody was a patient that had removal of their breasts, or mastectomy, what we call it. They're a cancer patient. You want to make sure that the blood, that it's not tight, because if you did that and they had their lymph nodes removed, you can cause a lot of lymphedema and stuff swollen, and so you would have some issues with that. If you had patient, like I had a patient one time when I first started nursing that had mastectomy in both arms, then you have to do the leg. You have to go to the leg. So we have a thigh cuff, and there's an alternative way for the thigh cuff. You can listen, you can put it above, around the top part of the leg, and you can listen to at the popliteal artery. So that work with the thigh cuff. So you can put it around right above the popliteal space on the front, and then listen at the popliteal artery. But you have to press it a little harder. It's a little harder to get that pulse there. Okay, so what we're going to do is we're going to make sure we got the pulse on. We're going to make sure our stethoscope is cleansed. By the way, we no longer, if you're used to wearing a stethoscope like this, we no longer do that. We have patients that are confused, and they can take the stethoscope and they can strangle you with the stethoscope like this. So we never want to wear it. Always want to wear the stethoscope around our neck like this, and we don't want to wear them room to room anymore. We want to take them off when we're not using it, because it spreads infection. So if a person is wearing this all the time, you're going to one room and another, you can get infection. And if you have somebody that has dementia, and they go to pull this, guess what? They can pull it like this and come off, and it's not gonna strangle you. All right, so we're going to make sure we're going to listen at the artery. This is called the brachial artery, so we have this over the brachial artery. This is called the bulb here. You're going to righty-tighty, lefty-loosey. You're going to make sure you put this right on the artery. You're going to put this in your ears. Again, we cleaned it before we put it on the patient. We already cleaned it previously. You don't want to make sure you use your thumb. You're going to use your 2 fingers. Hold on to the. This is called the diaphragm for loud sounds, and the bell is for small sounds. But we're going to listen the diaphragm. We're going to put it on here. we're going to pump this up. We're going to start out and we're going to pump up to 80. Now what we can do is, a lot of times what I do first is I go and I'll pump it up to 80, feeling my brachial pulse, okay? This is the correct way to do it. I'm trying to palpate the systolic blood pressure. It's estimated systolic blood pressure. So I'm going to pump it up to 80. Each little line on here, there are by tens, and each little line is 2 millimeters of mercury. So I don't want to see a 123/75, because each line is 2 millimeters of mercury. So I'm going to press this till I get to 80, and I'm going to keep going up until I no longer feel the pulse, by 10 millimeters of mercury at a time. So when I no longer feel the pulse, I'm going to stop, and I'm going to pump the blood pressure cuff 30 millimeters of mercury above, so I don't miss hearing the sounds. So then I'm going to take my stethoscope, put it right on up there, and I'm going to start using my thumb. I'm going to bring this towards me, and I'm start loosening it. I want to go only down about 2 millimeters of mercury per second, until I feel the first sound, which is like a tapping noise. This is a Korotkoff sound. So I heard the sound at 110, so I'm going to keep releasing this. The first number is the systolic number, the ventricle's pushing out blood, until I hear the last sound heard. Then all of a sudden it goes silent. The last sound heard is a diastolic, that's when the heart's at rest. So I got 110/60. So I'm going to make sure I didn't get any clothing in there. I'm going to make sure that I don't have, if I didn't get the reading right away, I'm going to make sure that I'm going to wait 2 minutes in between reading before I pull it up. I'm going to make sure I take this off their arm, because I don't want their arm. I've seen people with blood pressure cuffs stay on too long, and it caused their arm to turn blue. Okay, so I'm going to make sure I take that off. The reason we wait 2 minutes in between readings is because we allowed the vessels to return back to normal. So I'm going to write in my blood pressure, and it was 110/60. I'm going to write it like a fraction. Systolic over diastolic. Mr. Pierce, your blood pressure is in normal range. We try to keep you between about 120/80 or less. I see your last blood pressure. I'm checking your baseline. It looked like you were around 120/80, so that's pretty good reading in there. Since this is the first time I saw you, I took your blood pressure in both arms, and we used the highest reading. But since this is my second time seeing you, then I don't have to do it in both arms. Now, in order to diagnose a person, which we can't diagnose, but to determine if they have hypertension or not, you have to take 2 separate readings 2 different times. And you take both arms, and chances are you're going to have both arms. There's going to be about a 10 millimeter mercury difference on both arms. Okay, so I looked for the trends already, and I'm going to also look at for corresponding change in pulse rate, because sometimes the blood pressure go down and the pulse will go up. They could be like going into shock, something like that. So you want to be careful if the blood pressure is slowly decreasing, or if it's slowly increasing, they can be filling up with fluid and have hypervolemia. Okay, and if I couldn't use the arm, I already documented the blood pressure. If I couldn't use the arm, I'm going to write a reason why I couldn't use the arm if they had the dialysis shut. And of course, I'm going to be within 4 millimeters of mercury for the examiner. And these are the standards for the tech standards that I got from the packet from the testing for the techs at the state level. So I keep up with those trends, and I put that on. I add that to your competencies as well, because at the end of first semester, you're allowed to take the tech test, or we call them in California nursing assistants. Okay, so when I'm done with that, so I'm going to make sure, Mr. Pierce, thank you so much for letting me take care of you. Are you having any pain, anxiety, any discomfort, anything like that? Can I get you anything? I'm going to make sure I put your bed down so it stays at a safe level. And I'm going to put your tray table down with you. Make make sure I have your call. Are you in pain? Nope, you're not having any pain, so I'll make sure if you were having pain, I'm going to use this pain assessment scale here on a scale of 0 to 10, 0 being no pain to 10 being the worst possible pain imaginable. I'd have him give me a rating if he was having some pain. So I'm going to make sure I clean up my mess here. Make sure I got all my equipment put together. Mr. Pierce, if you need anything, just give me a call. You can push this button like this if you need anything. I'm going to make sure that, and his body is in straight alignment, so I don't want anything to happen to his back. Okay, I'm going to wash my hands, and I'm going to go immediately out to the nurse, and I'm going to, and especially you're going to, at the hospital, you're going to go right away, report your findings to the nurse, report your O2 temperature, pulse, respiration, blood pressure, and O2 sat to the nurse, and especially if people have abnormals, you don't want to wait, you just want to go right out and report them.